Dear Chairman, dear ladies and gentlemen, now this is a topic that might be at least of interest for 30% of the audience, because that is the normal percentage that the population is suffering from these so-called craniomandibular disorders. Now, what is a craniomandibular disorder? Actually, this is defined by pain, facial pain, typically radiating pain, often starting from the mandibular angle and then going up to the temple. Yeah, sometimes very, very strong pain. Yeah, during night times, in the morning, during a stressful day, really bothering people. Now, this pain actually can arise from the chewing muscles, yeah, mesenteric muscle, pterygoid muscle, temporal muscle. Of course, also a trigger can be the TMJ itself. Yeah, overstrained muscles can be caused by clenching, grinding. Yeah, and then this can also have an influence on swallowing. Yeah, swallowing can become even also painful. Yeah, people describe that they are suffering from headaches and also neck pain. Pain of the spine is often associated with the issue. Anyway, yeah, most importantly, we have to know that finally these several symptoms are relatively unspecific. Now, when we want to make the diagnosis, craniomandibular disorder, it's very important, and I will spend a few minutes on this, that we rule out other conditions. And sometimes, yeah, things can be very easy, because then you think that you have facial pain, craniomandibular disorder, but in reality, it's just decay of teeth. Yeah. So actually, the first step always is to look into the oral cavity, and of course, to at least take a panoramic radiograph, yeah, to rule out these issues. Yeah. Periapical infections, especially, yeah, can make pain that is absolutely comparable to what is happening during craniomandibular disorder. Then, of course, yeah, there are the diseases of the paranasal sinuses. Yeah, for example, here of the maxillary sinus on the left side. Yeah, finally it's completely filled with pus. Yeah, it's an iatrogenic issue here. Bony augmentation has been performed. Yeah, but finally this didn't work out well. So instead of diagnosing the patient with craniomandibular disorder, yeah, once again, we have to look deeper into this. Yeah. Now, what we need is a CT scan actually, and then we take the correct measures. Here, it's opening up the maxillary sinus and drain the pus. Of course, also remove these bone substitute materials, and then the patient will be fine again. And definitely, this is not craniomandibular disorder. Now, of course, yeah, cancer of the tonsil. This can also produce the same pain issues. So, before we make the diagnosis craniomandibular disorder, we really have to do a comprehensive examination of the patient. And of course, we need adequate diagnostics. This is a strange case I had some years ago. This patient went from doctor to doctor with pain of the mandible, with pain of the lower jaw, and she always felt that everything, that the whole pain was projected into a dental implant that she had received some months before the pain started. And then, finally, by coincidence, before a different surgery, I think to the leg, a chest x-ray was taken, and later on a CT scan of the chest, and then, of course, everything became very plausible because she had a large tumor of the left lung. Yeah? And this is suddenly explained the strange sensations and pain sensations she had in the neck and the left half of the face. So once again, it's very important to have comprehensive diagnostics. Now, another condition that makes completely the same pain as craniomandibular disorder is primary chronic osteomyelitis. Now, we're not talking here about bacterial osteomyelitis. Yeah? This is, of course, the old term, but it has never been changed. Of course, in the past, it was thought that this had to do something with bacteria, but in reality, this is something like an autoimmune disease. Yeah, you see the left side of the mandible, which is thicker with a denser bone. And what's happening here? Actually, this is some kind of autoimmune disease triggered by the body itself with more bony turnover, which causes the pain. And now, actually, the treatment is not surgery. The treatment is administering cortisone systemically and, for example, using also denosumab systemically, yeah, to treat the disease. Of course, the increased volume will stay, but afterwards, the patient is free of pain. So once again, this has to be taken into account. Right? And now, another thing that from my point of view is definitely underdiagnosed. Yeah? It's Eagle's syndrome. Yeah? Eagle's syndrome, of course, is caused by an elongated styloid process. So in females, it should be longer millimeters. In males, it should be longer than 35 millimeters. And once again, it causes exactly the same problems like craniomandibular disorder does. Swallowing problems, radiating pain, tinnitus, headaches, pressure on the eye, all these things are caused by the megastellate, how it's also called. Now, unlike for craniomandibular disorder, of course, here's a surgery for it. Yeah? And the surgery is just removal of the megastellate. Yeah? There are different approaches. Yeah? You can approach the megastellate transcervically. Of course, you can also remove it from an intraoral approach. But finally, yeah, if you want to take it out completely, and sometimes you even have calcified ligaments, then definitely still you have to do the transcervical approach to remove the megastellate. So once again, it's very important here to have the correct imaging and of course to be able to interpret the imaging. Yeah? Because once you know that this disease exists and that it really is relevant, you will diagnose much more patients with this condition. There's the simple surgery for the removal of the megastellate, and here really directly afterwards you have the immediate effect. So over 90% of the patients, and the literature even says in some papers, 97% of the patients are free of pain after the removal of the megastellate. Also, there's the so-called elongated period hammerless syndrome. Yeah? It's something comparable. Yeah? Once again, there's a structure at the end of the palate, just a little bit longer than before. There are lots of muscles around, and these actually can be irritated. Then the patient also gets swallowing problems. The patient gets problems during speech, chronic pain. And once again, the therapy is removal of these small bones. Now, before I go into craniomandibular disorder itself, I want to talk a second about the TMJ and the cartilage that's inside. You might have already seen it on the drawing that I have shown before that also clicking and locking of the joint belongs to the symptoms of craniomandibular disorder. But it's most important to know that pure clicking of the joint of the TMJ is no indication for surgery, yeah? As long as it does not go along with pain, of course. Now, where does the clicking come from? Typically, the articular disc should be positioned over the condylar head and should move simultaneously with the condylar head while we open the mouth. But once again, in about 25% of the population, the articular disc already is positioned anteriorly when the mouth is closed. Now, when we open, we first have rotation of the condylar head and then translation anteriorly. And by this translation, the articular disc is compressed. If the condylar head jumps underneath of the articular disc, then typically we hear clicking. If it is unable to jump underneath of the articular disc, then typically we have what we call a closed log, which means mouth opening is only possible for a few millimeters, but not for over 3 millimeters, what is considered being normal. Now, as I said, as long as clicking is without pain, there's no need for any treatment. Of course, we have surgical options to bring the articular disc back to the normal position, but it's not mandatory as long as there is no pain. Anyway, yeah, if you have pain issues directly projected into the joint, then the first step always is to do or to treat it minimally invasive, which means in this situation performing arthrocenthesis and lavage. So what we just do is to let flow saline solution through two cannulas in and out of the upper joint space. And while the saline solution flows through, we move the mandible back force to the left, to the right, just to mobilize it. And the reality is that this has a high percentage of or might occur in a patient that is suffering from craniomandibular disorder. So bruxism is not the same as craniomandibular disorder, but it belongs to this symptom constellation. Bruxism, of course, it's clenching, grinding of teeth. Yeah? When you look at this image here, this is a canine. And typically, when it's new, it has a tip. And this tip is gone because of wear, because of the permanent grinding. And if you leave the patient untreated, the next thing that you find is, for example, chipping of the animal. Yeah? Now we have a major damage of the teeth. And there's a simple solution to this issue. We give these patients mouth guards. So one major effect of a mouth guard is that it stops the wear of the teeth. So this is very important for people who suffer from bruxism, especially those who suffer from sleep bruxism. We always distinguish bruxism that we have during sleep and the bruxism that we have during daytimes. Especially in sleep bruxism, we need additional diagnostics. For example, this can be related to sleep apnea, so we also need sleep studies when we want to treat the patient comprehensively. Of course, here you have a special kind of mouth guard that also changes the occlusion, and the idea behind is to change the reflex patterns of the muscles when there's a contact between upper and lower dentition. So this also can reduce the tendency towards bruxism. Now, bruxism can go along with the hypertrophic mesenteric muscle, yeah, which typically causes what we call a square face. This nicely shows the overactivation of the muscle. Of course, in a patient like this, mouth guard is a good treatment. Of course, she has pain, so she will need painkillers. She will also need physiotherapy, but physiotherapy can be very ineffective if the muscles are very painful, and especially pain is caused when we press on these muscles. So what we need actually is an option to inactivate these muscles. And of course, this is done by the injection of Botox. Often when I discuss with patients, they don't understand what I want when I tell them I will inject Botox in the muscle, because often they confuse it with hyaluronic acid and they think it's just about aesthetics, but definitely it's not. It's to paralyze the muscle, to force it to relax, and actually to give a basis for more effective physiotherapy. So this is Botox is one of the important ways to treat or to allow good treatment of craniomandibular disorder. And of course, yeah, you cannot deny that decreasing the volume of the mesenteric muscle also improves the facial appearance, at least of females. Of course, if you have a hypertrophic mesenteric muscle in a male person, this even might support the masculine character of the person's face. Now, of course, you can treat that with Botox, or if you want to have a permanent effect, then there's also surgery for it. Yeah? And I'll show you the situation afterwards. So in reality, what I did in this patient is I removed the mandibular angles. Now, of course, the attachment for the mesenteric muscle is gone, and also the attachment for the pterygoid medial muscle is gone, and now they cannot function normally anymore, and this also causes them to lose volume. And this actually creates this nicely oval face permanently, or this is a permanent effect actually. I have already talked about the TMJ. You can have pain directly in the joint. This will put stress on the patient, and then typically this is a trigger to activate the muscles. Then you get the overstrained muscles, you get more pain, you clench more, you grind more. So actually, this is a vicious circle. Also, the right side here, this is the unaffected side. You see the length of the ascending ramus on this side, and this is the side, the left side, with the arthrosis. Yeah, it's pronounced, and you see that the length of the ascending ramus is reduced. Yeah? A reduction of length like this has a direct influence on dental occlusion, and if dental occlusion is not okay, in return, this will activate the chewing muscles with more activity, overstraining, pain. So it started with pain in the joint coming from the arthrosis, and then it turns into a real craniomandibular disorder by the activation of the muscles. Now, of course, we can treat arthrosis itself. Once again, as it is, and this I forgot to mention, arthrosis of the TMJ is not wear. Yeah, it's not because there's too much pressure on the joint or something like that. Once again, it has an autoimmune component. Now, the body produces inflammation markers that lead to degradation of the bone. Yeah? And that also causes pain. And so far, we don't have any option to stop arthrosis in the TMJ. We can just treat the symptoms. And how can we treat the symptoms? Of course, first of all, this can be, once again, arthrosensitivities and lavage, because then we just rinse out the inflammation markers, and this reduces the pain of the patients in return. Of course, once again, it's temporarily, but often they are free of pain for 1 year. And what we also have to know about arthrosis of the TMJ, that typically it is active for 1 year, maybe 2 years, maybe 3 years. But at a certain point of time, it stops. Yeah? And then, even without any therapy, the patient is free of pain. That does not mean that after 10 years, there might be a new interval of active arthrosis. But this also means that with maybe 2 or 3 interventions, minimally invasive interventions with arthrosensitivities and lavage, we can bring the patient through these active intervals of arthrosis. Now, of course, if we get strong fibrosis in the joint, with reduced mouth opening, and of course with a severely damaged articular disc, then we have to consider surgery. This is the perforated articular disc. There's no way to repair it. When you have the perforation, then bone grinds on bone. This causes also additional pain. So the therapy always is removal of the damaged articular disc, and then we have the option just to fill up the joint space with fatty tissue, or, for example, to use cartilage. Both options work really well. So this is for the pronounced arthrosis with pain directly in the joint. And then, of course, once the pain level in the joint is reduced, the patient will have less stress, and this also can have a positive effect on craniomandibular disorders, meaning that overstraining of the muscles is also reduced. Now, this is another example of arthrosis, and what you also see here is that the condylar head on both sides is not positioned correctly in the articular fossa. And this also causes problems. Unstable bite. If the bite is unstable, then in return, you get overstrained muscles and craniomandibular disorder starts. Now, here, of course, we have the option of orthognathic surgery. Once again, you see a severely resorbed condylar head with the effect that the mandible has moved backwards as the consequence of reduction of length of the ascending ramus. And this, of course, can be corrected by orthognathic surgery. In this case, advancement of the mandible, or actually it's lengthening of the mandible. Works out well, balances the bite once again, reduces activation of muscles, and of course, reduces the craniomandibular disorder. Now, you see that we really have to deal with this issue on a regular basis. And once again, the point is, especially here for male patients, you see that the chin actually is relatively weak before the surgery, and afterwards it's adequate. Gives the patient a better masculine character as far as the face is concerned. Now, the time is already up, and I want to summarize. Now, the management of craniomandibular disorder is mostly conservative, which means we need a mouth guard against wear of teeth, and of course, to balance the bite. We need physiotherapy to relax the muscles, and physiotherapy will work extremely well when we have injected Botox into the chewing muscles, so typically mesenteric muscle, temporal muscle, pterygoid muscles, lateral, medial, because then the muscles are forced to relax, they cannot contract anymore, and then physiotherapy will work even better. Of course, in these patients, typically we will need painkillers. Yeah, definitely. Yeah, and of course, a lot of patients, they do not like to take pills on a regular basis, but it's our job to explain to them that treating craniomandibular disorder is a conservative issue and that it can take a lot of time. So unfortunately, if they want to feel better, they have to work with the painkillers. The important point where I spend a lot of time on in this lecture is the identification, of course, of the differential diagnosis, yeah? Because sometimes you think it's facial pain, or craniomandibular disorder, but in reality, it's cancer. Important to know. Now, if arthrosis should be involved, then of course, there's a minimally invasive way to treat it, or yeah, we really have to do open surgery with replacement of the articular disc with orthognathic surgery. So, that being said, you have seen craniomandibular disorder is a common thing. We have a clear concept for the treatment, with the important issue of ruling out other conditions that actually mimic craniomandibular disorder. Thank you very much.